slides as well. So if anybody needs to have additional information regarding the slides, they can do. It's very important just to kind of state at this point, these are the proposed plans that we have got, and it's nothing has been finalized. Whatever's been, what will ever be, what has been on the tender would have been finalized as well. So these are just proposals at this stage, and we can make some final tweaks as well. Okay, I'm just going to start. I'm sure we'll be getting colleagues coming in and out of the meeting. That's cool. And if there's any questions, I'll take them at the kind of the convenient spaces where I'm able to. If not, then I'll kind of address them towards the end of the presentation, if that's okay. Right, okay, so we're just gonna make a kind of formal start. I've got several of my team online today, and they will be putting some relevant links on there, such as the community health profiles, faith toolkits, along. So if this proposal or anything that you are not interested in, but you want to look at some of the resources that the team's made, then you'll have the availability in the chat in terms of some of those things that we have been talking about. Okay. So we'll make a start. So just setting the scene, I think it's fairly clear, and it's obviously publicly acknowledged in terms of the council of last year is not the council of today. In fact, the council of next week is not going to be the council of today. We're in a very fluid situation, a very dynamic situation where things are moving at pace. There are financial pressures around it, but currently at this moment, public health has a protected grant which comes from central government, and that's how we're able to operate. Nevertheless, we still would need our colleagues in BCC working in various areas that will help support our work. So we are part of the same kind of scrutiny and pressures around this. So this is being sort of cleared. We've been given the green light to kind of go ahead with this program. However, it's just having that little footnote that and caveat that things can change all the time as well. So just a few things that we have got running, which you may or may not be familiar with, is we do have a bolder, healthier strategy that's running up from 2022 to 2030. This is alongside with a wider piece of work which is within the council, which is powered by people. And this looked at an exercise of how citizens engage with BCC and found there was something like 69 different avenues that were available from citizens to get in contact with BCC. Were they all great? No. Are we able to do something about it? Yes. So this is part of that program and some of the findings that came out of it. It kind of looked at a few different areas, as there's far less public money available than before, and many communities are stretched both within families and local organisations. So what we need to do is avoid making promises that we can't keep, and explores different ways of doing things and making most of everything that we've got. And one of my big pet hates is around sort of duplication. So we align and everybody's kind of working off the same page, and that exercise is happening throughout the council. The 6 areas of where we're looking to, or where it focuses on, is actually epitomised by the Powered by People strategy, which is looking at converse, inform, consult, involve, collaborate, and empower. So this is really epitomised by some of our community health profiles work, which I'll touch on a little bit later, where I'll touch on it then, but it's really important to that this is the actual formula in terms of how we've kind of operated within our team. So just a little bit about the team itself. The communities team is literally about 3 years old, and so we kind of have it as in phases. So the first kind of phase was looking at community intelligence and bringing knowledge of what do we have existing of our communities within Birmingham. The second part was around engagement and implementation of our work, what we've been doing. And then the final phase is around the evaluation and learning from what we've taken from the program. So we're now in kind of a little bit of end of phase 2, but firmly in phase 3. The next project, which is this around deep engagement partner work, is moving into kind of phase 4. And apologies to those who are with the Marvel analogies, but this is the phase 4 kind of area that we're in. But what it does look at is the characteristics of the community, and the powered by people plan defined it by place, identity, experience, interest, action, practice, and circumstance. So communities of place, communities of action, communities of circumstance. So the role of kind of public health then is looking at the three fundamentals, which is around health improvement, health protection, and health services. And you'll probably get this from any kind of generic public health presentation that you get. But how have we kind of done that? I'll move it on to the
Sorry to
next
interrupt
part.
you, Ricky. Someone
Sorry.
can't see the slides. Is anyone else having the same issue? Or can everyone else see the slides?
Fine for me.
It could be a case that if the person can't see it, might be if the cameras or the bandwidth issue.
Potentially leaving and come back if everyone else can see them.
Yeah, if not, then we will send it you. Then unfortunately, you might just have to listen to my voice only, and I'll try and explain it as much as I can in the flow. What we've also got is taking in consideration of some of what our stakeholders, partners have got, so that we know that the West Midlands Combined Authority are working on a communities kind of strategy as well, looking at our regional partners in public health, their strategies of engagement. But we are blessed within Birmingham because of the treatment system of what we have and the size of public health. We're able to kind of have a kind of well-defined and resourced team in order to do this work, but ultimately utilize some of those voices to help influence and shape the next phase of our commissioning is vital. And this is what the Deep Engagement Partner program is looking at. So just to kind of give you an idea of what we've achieved, especially in the first 3 years. So one is that we looked at the Birmingham's census information that came out very early on, and what we were able to do is kind of define some of our populations of who we've been working with previously, and see what the kind of next tasks that we had to do. The big kind of headline was that we were a super diverse city. So we knew that the majority of the bigger populations, such as the Pakistani, Indian, Bangladeshi populations, have grown within there. We're still one of the youngest cities within Europe, and interestingly, about how the emerging communities that were being defined within the census is something that how we kind of it's an exciting prospect for us to work with. So what we ended up doing was it was a task that Justin, our director of public health, gave just before COVID had kicked in, where he set up the team and said, Ricky, we want to look at a health profile of a specific community around it, and said, this is the task, crack on with it. Didn't really know the much kind of structure in terms of how we were going to operate around this, but he knew it will work once he sees it. So what we did was we looked at the health and wellbeing strategy, and we looked at the 10 themes that make up the strategy. And within that, we wanted to tell a story that if you're a particular community based on ethnicity, disability, faith, and sexual orientation, what does it mean from a health point of view living within the city? Not just that, not from in terms of engaging with organizations, but from published health literature. So desktop reviews of what's out there, not only to find out what the story is telling, but also what the gaps are in data, for us then to try and influence those systems in order to get better data coming in. And one of the massive learning lessons through COVID has been the importance of data and coding, of how multiple different ethnicities would be missed within the data sets. So these are available on the BCC website, and one of my colleagues will be put in the chat a link to these profiles. Thank you, Jordan. And now we have got the full 25 profiles that we've done online now. What we've also done is a task that we undertaken and just finished is those profiles that we had just done before the release of the 2021 census data. We've retrospectively gone back and added in an additional sort of forward page in terms of the latest update in terms of demography. What we're also trying to do is to influence a lot of the regional partners of ours. Obviously, we know that communities don't necessarily just stay in one place. That to basically give an update from their area of residence and their demography added in there, because the published health literature, 90% of it will still be relatively the same. The 10% will be the nuance in terms of where people are actually living and can actually have that more bespoke within there. But it's been a really fantastic piece of work for us to do. It's very rewarding in terms of saying these are the issues within there. These are the positives. These are some of the negatives within there. But then also empowering organisations to utilise these profiles as a sound foundation in terms of however they use them for their own bids for different funding streams and so on. What we ended up doing with this was towards the end of it was actually commissioning organizations to actually identify 3 of the health inequalities identified in their profile, and then try and do a little bit of a Kickstarter program if they could do a health campaign or an initiative around that. This, alongside some of our projects, are being also evaluated to see if this is any good, because there's no point in me just keep saying this is fantastic, but if they're not being used, then that's also really important for us to know and learn the lessons on as well. Sorry, I'm just having a bit of a technical, just bear with me 1 second. Okay, here we go. So some of the key findings that we've had, so you can see some of the stats on here, and I'll just give a couple out for those who can't see, and relating to the actual profile where they've been taken from. So we looked at dental health, we've looked at pollution, looked at education and access to services as well within there. So if we look at qualifications within the Somali community, in England and Wales, 33% of Somali population have no qualifications, and the average is 18%. So these are key statistics that will just come that came out of it. And also for those people who don't necessarily want to read the full document themselves, we've created some infographics that summarize some of the findings within there now, fully referenced. Okay, so the engagement, as I mentioned, where we've commissioned some partners to address inequalities within the profile. We've had to do different approaches, especially within the Indian and Pakistani one. We really struggled to get some of those organisations to apply for the tender, and that was because some of the nuances or the organisation may not exist in there. So we have a kind of a double job there, is putting those opportunities out, but also trying to stimulate the market and help create organisations and health academics, especially within emerging communities, to apply for some of these tenders. Now, before we kind of move forward, we know that the BCC tendering process is not the easiest at all, but it's the only kind of operating system that we can actually utilise and put out there. But just within our team, in the 3 years, we've commissioned out something just over about over £1.5 million worth of tender opportunities for communities out there. So many organisations who have attended this session and the one before have been really excellent partners for us to work with. And the deep engagement part, which is the next phase, is utilising some of that knowledge around. Yeah, so we do have kind of like in terms of engagement, we have the Blatcher program, which is a really trailblazing project nationally of Birmingham working with Lewisham Council and around the Black African Caribbean communities, looking at the health inequalities. And there's a big report around that. So we'll put that link in the chat as well. We also then have non-commissioned engagement with the wider council around the faith covenant groups. Looking at faith organisations around Black-led churches, and many other different kind of stakeholder areas of where public health is linked in. So I won't go into that. I kind of discussed that already. So I'll move on to this. So I think this is the reason why we're here today, for us to kind of look at what the next stages are. So some of the learning that we've come through was to have kind of a sustained relationship with those organizations and providers of communities who we've worked with, understanding in our short period of time that sometimes by working with providers, by the time everything's been set up and there's a momentum and a rhythm come in, it's the end of the contract. And how do we build up that sustainability and that little bit of a legacy relationship with organizations, and from ultimately building experience and shaping the next kind of cycle of commissioning within public health. I think what's kind of alarming is sometimes when you see, even in other systems in other areas, providers being still commissioned on based on old data, utilizing the old census, for example, not understanding the assets of the communities that they serve in the local area. We've been lucky that from the work that we've done, we've got that as an asset for us to understand, and also through COVID to carry on those relationships with communities, for us to move forward. So we have broken it down into kind of 5 objectives of what we want to do working with communities in this program, which is around looking at increasing awareness on community experiences of health inequalities, improving community health literacy. So this is a really big one of how does an individual understand the health literacy. How do they navigate around the health system internally within a workplace can be difficult, but outside of it, it can be more trickier. Where do people go and get support and help? So how do we bring up that health literacy is really crucial. Enhancing community capability for collective control of programs to address health inequalities. So knowing to go and get support, being that community voices. So this is a little bit different, where we've had organizations who have represented communities for decades within the city, but do they truly represent the intersectionality of that community? That's the challenge, and that's what we want to kind of help promote and be a little bit different moving forward. And then also the final one was to utilize existing community strength and capabilities to identify and provide solutions of community health. So this is not just us around prescribing what we think is good for a community, asking, identifying and knowing what the actual help they want, rather than just being kind of universal in some aspects and just throwing out what we think is right. So what it comes down to in terms of the offer, what we're doing, this is around focus groups, public health engagement. So this is where we utilize them not just for this program, but to influence the wider public health commissioning that we have and the relevant other departments around it. So it's not just for one area. It's how do we use the experience to help influence smoking cessation or sexual health services or substance misuse. And then also around sort of training, e-learning. So another big thing that we're working on in a separate project is around bringing a cultural health framework, and that's utilizing some of our the experience around cultural competency for healthcare professionals. So this is just in the pilot stage. So some of you may be aware that we're just in that pilot phase for us to do that. But we also are helping and reporting on evaluation requirements such as like DPH annual report, checking the metrics are correct. We'll be having monthly meetings with BCC, with Birmingham City Council, and feedback on the community health profiles work as well. So this is just showing of what we've just proposed, going back to those 6 things which I mentioned at the beginning of the presentation around converse, inform, consult, involve, collaborate, and empower, and how what we're proposing actually hits the Powered by BI strategy within there. So the next stage. So what we're proposing at this point, let me just make this a little bit smaller, is it will still be broken up into 4 areas, which is ethnicity, faith, sexual orientation, and disability within there. So we would have 5 lots that we're proposing for communities of ethnicity, 3 lots for faith and communities, and 2 lots for LGBT plus communities, and 3 lots of communities with disability. So these are in total 18 contracts that are available for people who would want to work with who'd want to bid for each of these areas. So for the 5 lots of communities of ethnicity, we're proposing 1 for a South Asian partner, 2 as a Caribbean, 3 as an African partner, 4 as Central Eastern European partner, and 5 for a Chinese partner within as an organisation. So the information where this has been taken up is from 288 category data sets of ethnicity from the census, and looking at the largest populations that we do have. Before it goes any further, those populations who we haven't identified or we haven't proposed, we do have other community health profiles of emerging communities coming through as a program. We also understand that we will not be able to serve every single community within the city. So this is for the first lot of first try of this deep engagement partner of the communities that we are identifying. So the next part was 3 lots of just the technicality. So the whole project in itself that we're looking at is a 2-year project with an optional 3rd year. So the whole program in itself is over excess of £1 million that we're putting towards this. So the commitment from public health is massive, and the wider council, from the leaders of the council, to do that. So I'll probably go this into a little bit later. So each lot has a maximum of kind of 30,000. So if you wanted to apply for as a total lot, it'll be 30,000 for South Asian, or you can apply for just individuals within there, which is a 10,000 per contract. And this will be just per year, and then you'd be able to, it will be, let's say for example, if it was just 1 South Asian, that would be up to 90,000 that you'd be if it was ran for 3 years. So this is, from our experience of what we've been learning and what we put through, and also the procurement framework that we're able to operate at the moment, this is kind of the proposal that we're able to do. If there's a bit too much information and you need some more technical information, when the tender goes live, there is a section in terms of where this is actually explained in a lot more detail for you to go through as well. So there's three lots for faith communities, which is looking at Christian engagement partner, including Black-led churches and South Asian churches. Muslim engagement partner, including South Asian Muslims, Arab or Middle East Muslims, and the 3rd one, which is looking at the Sikh community. The 2nd one is LGBT plus engagement partner, including lesbian, gay, and bisexual persons, and the 2nd one will be a trans engagement partner. And the final one would be deaf and hearing loss engagement partner, sight loss and blind engagement partner around it. And the 3rd one is an open-ended community at this moment. So we're just finalising what the semantic and the specification of that one would be. So as I said, it is fluid at this stage for us to kind of work through. We have got a separate the community health profiles, which I mentioned earlier, where we had 25. There's still some opportunities that are available within there. Yes, there's still some optional information that's on there around some tenders available for Irish, the Chinese, and the last one was I've gone blank for a second there, Jordan. Do you want to just chip in for that session? The 3 providers.
So we've got a 12-year pilot program. We'll be focusing more on the community health profile specifically, with the Irish community, the Gypsy Roma traveller communities, and the Chinese community.
Yeah, for the GIT.
There's also a question in the chat from Heather saying, why no African and Caribbean on slide 25?
Just bear with me, slide 25.
I think that's the slide we're on.
It's
just because I think it wouldn't all fit on the one slide.
Yeah, it wouldn't fit on there. Let me just see for it's got. Yeah, it just didn't fit on the slide, but it is included on that one. That's just a slide technical on there. So thanks, Heather. We appreciate that. Let me just bring it together. So at this moment in time, there's 13 available lots with a maximum of 18 available contracts, maximum of 30,000 per year for each lot that it's broken into. And then there'll be initial 2-year contract with the option of a 1-year extension. So they are sublots that will be funded proportionally to the total lot, and there are some consortium bids that are welcome. So it is, in terms of like from the learning that we have got, and some of the feedback we've already received from our partners of the best way of trying to get this out. Now we know that we might not get everybody bidding for everything straight away. It might just take a little bit of time, but we're here to try and make this process easier for you guys, because then ultimately it helps us in bringing this forward as well. Yeah, so Fatima makes a really good point here, and it is one that when we do go live, we are speaking with procurement just to go with some of the technicalities in terms of how to apply for this, because it can be a very tricky process, and I've said on record, and I've said it here, and even our director, it's the only system that we're able to do from a BCC point, to help that. Now we are limited in terms of us, once a tender goes live, for us what information that we can do, because we can't be seen to be giving favourable information. So before it actually does go live, we're trying to see if we can get a bit of a session around in terms of how we can actually help organisations put in better sort of tenders for that. There may already be a presentation on the Healthy Brum YouTube channel, which does have quite a lot of gold on there, where they might actually already go through that one, but leave that for us for one of the actions for us to take forward to see whether it's possible. We'll try and get you an answer either way as well. Okay, so what we are also doing with this, before I kind of close, and if there is any more questions, is we're also getting an academic partner to help support some of the data collection. So what's been a learning process for us is not all organisations are equipped in terms of how to monitor data and collect data. So an academic partner who would be working with the project will be there to support all the providers who are in there, to help kind of get a standardized data set for us to collect that information. And then what that allows us then to do is to do a bit more of an effective evaluation, because if in the future, if we wanted to run it through, it's no good just my opinion or anybody else's opinion. We need to understand what the lessons are. And it's just important at this bit, we do have evaluation partners for the Blatchier project proposed, the community health profiles that we've proposed, and the healthy faith-based toolkits that we have, which is another project, and for this one. So there is a lot of learning. And when I was talking about having phase 3, this is the real gold, in terms of saying no point in doing all these reports if they're just collecting dust. It's just for us to kind of we need to understand the learning around that, and that is one of the key principles that Justin's put forward around, especially this year. As finances are going to be tight, we need to justify why we're making these decisions. So with that in mind, and it's important to kind of, for me to mention, is that this program may hopefully suitable for all, but for some people they may not be interested. What we have got are some other opportunities that will be coming out very shortly. So we have an emerging communities project. So those communities that don't necessarily have enough health data out there, but do have some, we still want to work and put together probably a master profile with loads of different communities of the available health information that we have got. And the potential then is to go out for a community provider to do some engagement work with that. What that looks like, we're still in very early phases. We're still putting together the data information, but that may be something for next year in terms of 24-25. No, sorry, 25-26. We do have those. We will be having 3 tender opportunities available around the Gypsy GRT community, Irish community, and the Chinese community out shortly. And then there is a wider piece of work around cultural humility and intelligence framework, and other opportunities that may be supported around Blatcher in the future as well, which we're coming towards the end of that phase 1 and then going into kind of phase 2, which is really moving into this deep engagement partner work of having those sustained long-term relationship with community organizations to build up the learning and more importantly, building up the communication. So I'm conscious I've talked for around about 35 minutes there, and there's a lot of information that's gone through, and I'm not expecting everybody to kind of pick everything out of there. But I can answer a few questions if anybody has got any more clarification between either myself and the team to give that information. Anything that I can't answer, I will go away and find out and get back to you and give you an answer that in that way. Amita, how you doing?
How you doing?
Hi. Can you hear me okay? Is that all right?
Yes.
Yes, I can.
Brilliant. I was just wondering about that academic partner role. Like how that comes about, or what the process is, or if you already have that in place. You mentioned that you have something, evaluation partners with the Blatcher project.
Yes.
So we have.
Oh,
I've got an echo on that.
It might be.
It might be.
Yeah, so the specification for the academic partner hasn't been fully finalized yet, but does follow the rhythm of our Blatcher partner that we've got, and for London School of Economics that we got for the community health profile as a partner. So these are kind of the headlines from it. From the specification and the tender, but we are proposing for that to probably come out after probably in the next couple of weeks. We might launch it together because it does make sense for us to launch it together, because we need to have that standardization and making sure as organizations are coming on board with the program that it fits that it's all in tandem. So answering your question, not at the moment, that it's still proposal, and we've still got it in draft privately. We're still working with procurement and public health in terms to finalize that spec. But then after that, we all have the potential then of kind of sharing all the information at the same time, because we want to make sure that everybody's working together, not separately. The problem is that it's most likely going to be staggered anyway, because we might not get everybody applying, or the quality of bids that are coming in might not be acceptable. So I'm a little bit, I can't give you an absolute in terms of whether it's going to be at the same time, but the idea is for it to work together, but the specifications are just getting tightened up privately.
Thank you.
Heather, I'm sure it was Heather first. I'm sure you came up on the screen. Heather, I apologize if it isn't. Is it yourself first?
It is me, yes. Thank you.
Thank you. How are you? Okay.
I'm fine, thank you. I just wondered whether you'd ever considered treating refugees and migrants as a community, because as you know from our work with the Nigerian project, there are very unique and specific needs that they have, separate from any of these communities.
Yeah, it's a really good point that you make there, and it may be applicable in the first project, the other project that I was talking around the community health profile, emerging communities, because having refugees obviously is a huge community within the city, and a consideration that needs to be taken moving forward. Now, I have heard in other parts of public health there is work happening, especially in the inclusion and inequalities team of working with migrants and refugees. So I can't give you a definite on that bit, but it is going to be included in our community health profile in the up and coming one. It may be a conversation, Heather, that we probably, as we're at this stage, still getting information together, that having a quick conversation offline in terms of things for us to consider in there.
Yeah, please do, because health literacy is one of the biggest issues with refugees and migrants. and that's what they're crying out for, is getting to know how things work and access.
No problem.
Thanks, Ricky.
No problem, Heather. Fatima?
Yeah, thank you, Ricky, for the presentation. And just two quick questions. So when is the tender going live? Is there any particular date?
Okay, I'll just answer. Is it just the one question or the second one? Is there something else?
Yeah,
I could feel you saying something else there, Fatima.
Yeah, the other thing was that you already know that we are working with some of the community groups that you have mentioned. And is there a way where Community Connections can support this work?
Yes. So the first question in terms of timings of when this is likely to go through. Now, what we have got is we've had the initial idea funding cleared internally with Public Health. It's also been cleared by our cabinet member, but it's then got to go to kind of full scrutiny, which is the last stages because of the financial pressures and what's going on, and the amount of money that's been aligned to it. It's got to go through further checks. So it is proposed for us to get an answer and clearance, hopefully within the next sort of 10 days. Once that, then it'll be very, very soon after. It shouldn't go, and I'm not hoping to curse this. It shouldn't go no later than the end of this month, end of February, and with start dates that we're looking for contracts to commence will probably May, June, being realistic once everything's been ratified around that, because once we go out live, then there's kind of a period where we have to advertise the tender, then procurement have to agree, then we have to do letters of getting them onto the system, then making sure everything's kind of in place. So it is a bit more of a long. Internally, it's long because potentially there's 18 different contracts for us to manage alongside the 25 profiles that we've got as well at the same time, plus Blatcher, plus the faith toolkits that we have got, and plus there's another stream that I haven't even mentioned that I manage, which is around public health and art and culture. So there is loads of moving pieces and spinning plates that we're doing, and throughout my experience, even that process can be 6 to 8 weeks just in itself. And the second part, in terms of partners, now one of the within the specification is about getting those organisations linking into other areas. So Community Connections and looking at the work that they've done was fantastic in the last month. And I have got your, in fact, here's the plug there, guys. It's a community engagement handbook which I stole from their desk. And it makes really good information about how to checklist in terms of flow charts of how to engage from the with communities, and it actually references the community health profiles within the Blatcher project as well. And for us internally, that's a job for us to make sure that we align with all of our knowledge and teachings with yourself and vice versa. But we're trying to build up a bit of a safeguard around that with the combined authority potentially having a new board where we're able to kind of bring everything together really in terms of sharing best practice. We would be encouraging the providers who be commissioned to work alongside you guys as well.
Yeah. Thank you so much, Ricky.
That was a very good politician answer.
I'll accept that. Thank you.
Yes. Thank you. Okay, I'm gonna pause. Anybody else for the final one? Otherwise, I'm gonna give you back 15 minutes of the hour, and really appreciate you guys taking your time out, especially on a Friday morning. We'll do our bit of notifying you guys of any questions or anything that's come through. Plus, in terms of the tender date of when it goes live, the other part of that. So the other bit is to kind of sign up to find it in Birmingham if you ain't already done that, and that just gives you all the kind of council tenders that are available. We'll try and speak to procurement to see if there's any additional things that we're able to put across and get around the application for tenders. There is a communities team email address which has just been put in the chat if you do have any further questions or ideas, and we'll take that forward. I just really want to emphasize the success that we've had internally and nationally externally around all the work is not possible without the providers who we've worked through, and also the team in my team who've been on the journey, who've actually produced the majority of this work, and help build up those relationships within the city. We are not going to change decades of inequality by one project, but we're trying to do it with a series of work that we're trying to understand and influence the next sort of lot and the commissioning cycles within there. So we're learning at the same time as you guys. We're going to make some mistakes, but it's about how we move forward from that and bringing it together. So it's a very transparent and an open relationship. And we'll be very honest with you of what we can do, but most importantly, what we can't do as well at the same time. So managing those expectations. I think the commitment in terms of what we've put and Justin's put through over £1 million already, and then what he's proposing now shows a real kind of commitment to the city. Okay, thank you guys. I'm going to have a coffee now because I was really stressed about this morning, and I really appreciate you taking your time out and all your comments.